Today, it will be a shorter presentation than the previous presentation on the malignant and benign gastric diseases. And in our talk today, we are going to focus on malignant small bowel tumors. So, basically at the beginning, I want to simplify the concepts of surgical oncology in general. And after I simplify those concepts, we are going to talk about small bowel tumors, starting with adenocarcinoma, followed by carcinoids, cysts, and lymphoma. So this is the Saudi Cancer Society logo. And in Arabic this is basically a tweet making fun of the Saudi Cancer Society, saying that, you should not put the animal or the crab as the sign of cancer. Yes, it is. Yes, cancer shares the name with the animal crab, but it's not the same. Now, many people might think that this is true, and it's not correct to put the animal as the sign of a cancer society, but actually this shows a deep understanding of the history of oncology. The physician Galen made the first description of cancer, and he did that by cutting or slicing through a tumor of the breast, and he saw that the tumor itself is originating from a focus, and from that focus you find arms or angiogenesis arising from the focus to occupy the whole breast. So he thought that the cancer is resembling the animal, the crab, in its arm that is spreading through the organ. So actually this shows a deep understanding of the history. And the oldest description of cancer was discovered in Egypt. It dates back to about 3000 BC. It is found in a papyrus called the Edwin Smith Papyrus, and it's a copy of an ancient Egyptian textbook on trauma surgery. They describe 8 cases of tumors or ulcers of the breast that they were removed by cauterization and with a tool called the fire drill. The writing says about the disease that there is no treatment for cancer. So for those people who think, who believe in conspiracy theory and say that cancer is a new invention, it is not. It is not a new invention. It is discovered since ancient times. Now, basic concepts of oncology. Cancer is the seed, the body is the soil. When you decide to treat cancer, you have to focus on the seed and on the soil. The seed itself, or the primary focus of the tumor, let's say a 2-centimeter breast cancer, that's the seed. To treat the seed, you need to do either surgery or radiation. Surgery carries the advantage of having an actual pathology and making sure that all the margins are removed, and it's in general associated with better survival than the radiation. With the radiation, you cannot get an actual pathological assessment of the cancer itself. In terms of the soil, the treatment, which is the whole body, the treatment is with chemotherapy. So you usually combine the treatment of the seed with the treatment of the soil. You do surgery, resect the tumor, and then you give chemotherapy either before doing the surgery or after doing the surgery. Now, how do you know that the cancer is actually reaching the soil? There are no accurate tests to do that. We do CT scans, we do PET scans, but CT scans and PET scans don't look at the actual cells that are circulating in the lymph or in the circulatory system. But you can predict, and you can predict whether the cancer is reaching the soil or reaching through the body by the following: aggressive features and pathology. So that's why you need to do surgery, take the tumor out, remove it, and understand its pathology. Sometimes you'll find aggressive features and pathology that will require you to do or to give chemotherapy. Then you look at lymph node metastasis and you look at organ metastasis. Of course, reaching, or if the tumor is reaching other organs, this is a sign of aggressiveness, and you basically need to be more aggressive with that tumor, or if the tumor is reaching the lymph nodes. So whenever you are learning about the tumor, you need to answer these questions. You need to know the answer of these questions. How does the tumor present? How can you detect it? Where does it go? Sometimes the tumor does not occupy lymph nodes. It can metastasize directly to other organs by hematogenous spread instead of lymphatic spread. From where is the tumor actually arising? How can we do local treatment for the tumor? What kind of surgery? Is there any systemic treatment available for it? What are the chemotherapeutic options available? Some tumors we don't have some good chemotherapy for some tumors. What is the survival after treatment? And how do you survey the patient after you treat the cancer itself? Now, in terms of the small bowel tumors, I need just to move this. Although the small bowel is a large organ, tumors of the small bowel, for some reason, constitute only 1 to 2% of all malignant tumors of the GI tract. Adenocarcinomas, this is a common MCQ question that comes up when we were students. Adenocarcinomas are commoner in the proximal small bowel, but other malignant lesions are more common in the distal intestine. The commonest malignant neoplasms of the small bowel are adenocarcinoma, followed by carcinoid tumors, malignant cysts, and lymphomas. In terms of the presentation of small bowel tumors, symptoms may include dyspepsia, anorexia, malaise, and dull abdominal pain. Weight loss, obstruction. The lumen of the small bowel is not very large, so if you have a tumor in the lumen itself, obstruction can occur at a very early stage. Bleeding, if the tumor is vascular, such as GIST tumors. Weight loss, we mentioned that. Anemia and intussusception. Perforation also can happen, especially in carcinoid and small bowel lymphoma or any other tumors. How do you diagnose it? Well, we know that the endoscope cannot reach. It can reach the small bowel, but it's difficult to do a routine endoscopy for the whole small bowel. So we use CT scan enteroclysis, small bowel follow-through, upper GI endoscopy if the tumor is in the proximal small bowel. If it's within the first 100 centimeters of the small bowel, you can do push enteroscopy. And you can also do capsule endoscopy. It's one of the relatively new investigative approaches. This is a picture of proximal adenocarcinoma of the small bowel. You can see in the middle, this is the pylorus. This is proximal to the pylorus, and this is the tumor itself. In terms of the treatment of adenocarcinoma of the small bowel, we know that adenocarcinoma goes to the lymph nodes. Therefore, you need to do an adequate lymph node dissection. So if the tumor is here in the small bowel, you need to get the mesentery and the fat around the mesentery, and you need to go high in the vessel to get as much lymph nodes as possible. So you will do a resection of the small bowel along with the mesentery with a high ligation to get as much lymph nodes as possible. And the chemotherapeutic options, of course, you need to discuss the patient at the tumor board, and after surgery, you need to discuss the chemotherapeutic options at the tumor board. Usually, you will use similar chemotherapy to the chemotherapy utilized in colorectal cancers. In terms of next, I'm going to talk about carcinoid tumors. of the small bowel and stomach. Carcinoid tumors of the small bowel arise from the enterochromaffin cells. They can be derived from the foregut, respiratory system, the thymus, midgut, stomach, small bowel, right colon, appendix even, and hindgut, distal colon and rectum. So they can arise from almost anywhere in the GI tract. Their presentation includes abdominal pain. It is also commonly associated with partial or complete small bowel obstruction. It causes a severe desmoplastic reaction, the tumor itself, that will cause obstruction early on in the tumor. Or it can present as a carcinoid syndrome. What is a carcinoid syndrome? Now, this is a picture of an intussusception. Now, what is a carcinoid syndrome? The syndrome is most commonly associated with carcinoid tumor of the GI tract, particularly from the small bowel. The classic description of carcinoid syndrome typically includes vasomotor, cardiac, and GI manifestation. Most patients, so in order to get a carcinoid syndrome, you need to have a massive hepatic replacement by metastatic disease. So if the tumor is from the small bowel, from the midgut, you need the tumor to be metastasizing to the liver in order to get malignant carcinoid syndrome. So it cannot happen in midgut tumors without liver metastasis. Now, the common symptoms and signs include flushing. So in 80% of patients, they will complain of flushing, diarrhea, hepatomegaly, cardiac lesions, most commonly right heart valvular disease, so a tricuspid valve pathology, and asthma. The syndrome itself does not come together. It doesn't present in a very classic way. Sometimes the patient will complain of severe asthma, or patients coming with tricuspid valve lesions, or patients just complaining of flushing or feeling hot most of the time. So you need to have a high index of suspicion in order to make a proper diagnosis and find or detect a malignant carcinoid syndrome. What investigations would you do if you think that the patient is having a carcinoid syndrome? So carcinoid tumors produce serotonin. Serotonin is metabolized in the liver and the lungs to 5-HIAA. What you need to do is you need to do a 24 hours urine collection to measure the level of 5-HIAA. That's how you make a diagnosis. You can also do chromogranin A, do a CT scan, and you can also do a somatostatin receptor scintigraphy. Now, this is a quote from Steve Jobs. Remembering that I will be dead soon is the most important tool I have ever encountered to help me make the big choices in life. Why did I put his picture? Because he was diagnosed with carcinoid disease. How do you classify neuroendocrine tumors of the GI tract? Carcinoid is a neuroendocrine tumor of the GI tract. There is a WHO classification, and you classify the patient according to the grade, the mitotic count, and the Ki-67 percentage. Well-differentiated neuroendocrine tumor will will have a benign behavior. Some of them will have, you can divide them into well-differentiated with uncertain behavior and poorly differentiated neuroendocrine tumor with high grade malignant behavior based on this classification. How do you treat carcinoid tumors? You treat them the same way you treat adenocarcinoma of the small bowel. You need to do a resection with lymphadenectomy because the tumor will metastasize first to the lymph nodes. If the tumor is in the appendix, I'm going to put a slide on carcinoid tumors of the appendix. And in patients with carcinoid tumors and widespread metastatic disease, those with carcinoid syndrome, you treat them symptomatically with somatostatin analog, such as octreotide. Now, In terms of appendiceal neuroendocrine tumor, it's important to know about them. They are rare, but sometimes you might go in as a surgeon, perform an appendectomy, and the patient comes with classical symptoms of appendicitis. You do the appendectomy, and the pathologist calls you 5 or 7 days later and tells you that, look, this is not an acute appendicitis. This is a carcinoid of the appendix. The majority of these tumors are benign. Carcinoid syndrome in those tumors is rare, but you need to know the size of the tumor. If it's in the appendix and it's only less than 1 centimeter, you only do an appendectomy. If the size is 2 centimeters and above, you need to go back and do a right hemicolectomy because you need to get the lymph nodes. Size of 2 centimeters in the appendix and above can mean that it's an aggressive tumor, and it might go to the lymph nodes, so you need to know the status of the lymph nodes. Or if the tumor is above 1 centimeter and very close to the appendiceal artery, you might need to go back. Of course, discuss it at your tumor board. That's the safest answer in your board's exam. Gastric neuroendocrine tumor, it's a relatively new diagnosis. Still, the guidelines are not very clear in terms of the treatment of gastric neuroendocrine tumors. They are very rare, but basically you need to know that they are classified into 3 types. Type 1 is associated with chronic atrophic gastritis, usually with chronic proton pump inhibitor therapy. It can be associated with pernicious anemia as well. They will usually have a benign behavior, and you don't need to do much for them except if you have a mass associated with it. Type 2 is usually associated with Zollinger-Ellison syndrome and Menon syndrome with hypergastриnemia. So you need to work patients up, rule out Menon syndrome, and rule out gastrin-producing tumors. Type 3 tumors are large, solitary, invasive, and they are malignant. They can also be associated with an atypical form of carcinoid syndrome. So type 1 is usually benign, type 2 and 3 malignant. Type 2 associated with gastrin-producing tumors, type 3 is malignant and aggressive. That's a summary of gastrin neuroendocrine tumors. Going to small bowel lymphoma. Malignant small bowel lymphoma involves the small bowel primarily. It can also be a manifestation of systemic disease. The small intestine is the second most common site of primary GI lymphoma. The stomach is the most common site. Lymphomas are most commonly found in the ileum because the greatest presence of gut-associated lymphoid tissue is in the ileum. There is an increased risk for developing primary small bowel lymphoma in patients with celiac disease and AIDS. The symptoms of lymphoma can include pain, weight loss, nausea, vomiting, and change in bowel habit. Perforation can be as high as in 25% of patients. The most common histologic type of primary small bowel lymphoma is diffuse large B cells. The 5-year survival ranges from 20 to 30%. The initial treatment of small bowel lymphoma is not with surgery, it's with chemotherapy. And surgery is reserved for intra-abdominal complications such as obstruction and perforation. You need also to watch patients after the initiation of chemotherapy. You need to watch for perforation in those patients. Now, I'm going to end my lecture talking about GIST. Take some water. So, GIST tumors originate from the intestinal pacemaker cells, from the interstitial cells of Cajal, which expresses CD117. What is CD117? It's a transmembrane tyrosine kinase receptor, and it's a product of the c-KIT proto-oncogene. They can occur from in the GI tract from the esophagus to the anus, but the most common, it is the most common mesenchymal tumor of the GI tract. 60% are located in the stomach and 30% in the small bowel. And overall, they constitute about 3% of all gastric malignancies. You can distinguish them from other mesenchymal tumors through immunohistochemistry, looking for the CD117, PDG-FRA, and the CD34. They arise from the submucosa. These are the layers of the stomach, and just are submucosal tumors. So you might get a report from an endoscopic ultrasound or from an endoscopy saying that there is this patient is presenting with a tumor from the submucosa. The key is submucosal tumors, just are submucosal tumors. Are they malignant or benign? Well, GIST behavior occupies a wide spectrum from benign to malignant behavior, but you should consider all GISTs as potentially malignant. The guidelines for classifying GIST as, so from the get-go, from the beginning, from the presentation of the patient, it's hard to tell if this GIST is benign or malignant. You need to take it out in order to know the behavior of that tumor, but you should consider all GISTs as potentially malignant. How could you predict the behavior of the GIST tumor after resection? You need to look at the size, if it's greater than 5 to 10 centimeter, and if the site and the number of mitosis, so more than 5 mitosis for 50 high power fields. And nowadays it's acceptable that with long follow-up, virtually all GISTs have the potential for malignant behavior. Even small GISTs, 2 centimeter or less, even those with favorable histologic features, with more follow-up, they can act in a malignant way. The most common indication for surgery includes bleeding and obstruction. They are very vascular tumors, and in the small bowel, they can cause obstruction early or in the GE junction. Typically, GISTs invades locally, and they spread by direct extension to adjacent tissues and hematogenously to the liver, lungs, and bones. It's very rare that GIST tumors metastasize to the lymph nodes. So you do not need to do a lymphadenectomy when you resect a GIST tumor. You just need to do an R0 resection of the tumor itself. In terms of the diagnostic workup, endoscopy is important. EUS is important along with a fine needle aspiration and CT scan. In terms of the biopsy, the tumor is fragile. You don't want to rupture it because rupture will make the survival worse. So you need to be careful taking the biopsy. It's a vascular tumor; it can bleed. So it's important. It's better to do an endoscopic biopsy using under endoscopic ultrasound guidance. Biopsy is essential if you want to do a neoadjuvant therapy of the tumor. Now, how do you stage it? Again, the most important factors in red here, you need to know the mitotic rate, the tumor size, and the tumor location. So with more proximal tumor, you will have a more favorable diagnosis. So tumors in the stomach will have a more favorable prognosis than tumors distal to the stomach. What about the principles of surgery? I mentioned before that the goal of surgery is margin negative resection with in-block resection of adjacent organs if they are involved. You should avoid rupture of the tumor because rupture of these tumors will spread it. Lymph node metastases, again, are very rare. Again, I'm emphasizing you don't need to do lymphadenectomy for GIST tumors. The recurrence is related to the mitotic rate, and the presence of deletion can be also related to the presence of deletion or insertion of c-KIT exon 11, and also male sex. In terms of adjuvant therapy, until recently, I would say about 15, 20 years ago, there are no adjuvant chemotherapy for GISTs. Radiation therapy has not been proved to be effective in the management of GISTs, and they used not to respond to chemotherapy. However, this changed with imatinib, Gleevec. It's a competitive inhibitor of certain tyrosine kinases, including the kinases associated with the transmembrane receptor kit and platelet-derived growth factor receptors. The initial studies showed very encouraging results, with 54% of patients showing at least partial response. This is one of the major studies on imatinib. They included completely resected primary GIST, more than 3 centimeter and c-KIT positive. They gave a 1 year of adjuvant imatinib, 400 milligram daily. They randomized patients to 400 milligram of daily imatinib versus placebo, and the primary endpoint was recurrence-free survival. The trial was stopped early when the planned interim analysis disclosed that significantly fewer patients in the treated group had recurrence. And since then, imatinib is approved as an adjuvant therapy for patients after the resection of GIST if the tumor is more than 3 centimeter in size. Now, in certain situations, such as an exon 9 KIT mutation, you need to give a double dose of imatinib. You need to give 800 milligram of imatinib. Some studies also, and in some centers, they can give it up to 3 years. In patients with platelet-derived growth factor receptor, AD842, you cannot treat the patients with imatinib because these patients will not be sensitive to the treatment. This is a large GIST tumor that we resected a long time ago. It's huge, as you can see. In particular situations, you try to give imatinib prior to surgery to shrink the tumor. If the surgery will be very major, such as a GIST of the GE junction that might require a total gastrectomy, you can give imatinib, shrink the tumor, and then you can do a local resection, saving the stomach, or GIST of the rectum where the resection might require an APR. You can give the imatinib in a neoadjuvant fashion to shrink the tumor and do just a local resection. So that concludes my presentation for today on malignant small bowel. Thank you.
Thank you, Dr. Mohammed, for this informative and wonderful lecture. If you want to take a few questions from the attendees and anyone want to ask a question, we have, I think, 2 questions in the Q&A panel. If you want to read them.
So, as a GP at primary healthcare centers, what are the red flags to suspect patients with small intestinal tumor and refer them urgently? I think, again, small intestinal tumors are very rare, but weight loss is a very important sign. If the patient is losing more than 5 to 10% of their total body weight without dieting intentionally. Now, when a patient tells you that he lost 10 kilograms because he's dieting, you need to be careful. You need to ask carefully about the diet history. Maybe it's not a true diet. Maybe he's not doing something different than what he used to do in the past. So don't take a patient telling you that he's losing weight from diet lightly, especially in patients above 60 years of age. Even if they tell you that they are losing weight because of dieting, you need to be careful and you need to do a proper history and examination to avoid missing tumors. So weight loss is very important sign that you can rely on. The second question from Ziad, how to approach resectable gastric GIST by endoscopic biopsy with resectable hepatic mets. Now, again, you need to discuss this at a tumor board. You can't make a decision as a surgeon or as an endoscopist or as an oncologist without discussing these patients at a tumor board. You can give imatinib and assess the response for the patient, and then you can decide whether you can go for a resection or not. Again, these tumors tend to cause obstruction and bleeding. So even if they are metastatic, sometimes you might need to go in and resect them. So yeah, central umbilication and ulceration in the diagnosis of GIST, can it be enough given the high risk of biopsy? No, it can't be enough. I think if you have endoscopic ultrasound in your facility, you should go for a biopsy, a fine needle aspiration at least. And if you go through the endoscopic route by a good endoscopist, you will reduce the risk of rupture, and it can give you information. Now, if the tumor is small, bleeding, symptomatic in the small bowel, you might not need to do a biopsy. You are going to go in and do a resection. But if the biopsy is going to change your management, if the biopsy is going to tell you that this is just and not adenocarcinoma, then it will change your surgery. Because again, in adenocarcinoma, you need to do a lymphadenectomy, but in GIST, you don't need to do a lymphadenectomy. So you need the biopsy. If the GIST is at the GE junction or in the stomach, you just need to remove the GIST itself. You don't need to do an actual resection with 5 or 6 centimeter above, 5 and 6 centimeter below. So you need to know what kind of tumor it is by a biopsy. But if the biopsy is not going to change your management, then yes, if the patient is bleeding actively, is having an obstruction, you need to go in and deal with it. Right. There are some questions about studying. I'm going to focus on the questions on GIST. If you resect a GIST and the tumor margin is positive, should you proceed with total gastrectomy or treat with imatinib? It depends on the site of the tumor. If it's not near the GE junction, you might not need to go back. Again, these type of questions are better suited for a tumor board, and the tumor board should decide on what to do in these cases. Again, if the margin is positive, then you probably should have given imatinib before, because usually it's hard to get a positive margin if the tumor is not in a sensitive location. Is colonoscopy a part of workup, especially if you find an appendiceal carcinoma? Yes, you might do a colonoscopy. An important point here is that in patients with GIST, they will have an increased risk of having other tumors. So you might need to do an upper and lower endoscopy in any patient with GIST as well. I think I answered that before. Better asked with regard to just when FNA versus biopsy. Again, I mentioned before that if you need to give neoadjuvant therapy, then you need to do a biopsy. Better is a great colorectal surgeon working with us, and you know better than me that if it's in the rectum requiring an APR, then you might need to do an FNA. In my specialty, if it's around the GE junction, then I might do it, or if I think that the biopsy is going to change my management. In general, EUS biopsy by an experienced endoscopist should be fine. You wouldn't have a problem with that. I would try to avoid percutaneous biopsy unless it's a must. But usually you don't need to do a percutaneous biopsy. Most of just 60% of them are in the stomach anyway, so you can reach them with EUS and biopsy. In terms of the mortality of small bowel tumors, it varies. Again, I mentioned that the small bowel lymphoma is about 30%. Adenocarcinoma is around that, 30 to 40%. Adenocarcinoma of the ampulla of Vater is about 50%. And so it varies in the location and the type. Any role of endoscopic resection in GIST? Well, it says submucosal tumors. You don't want to rupture them because rupture is associated with the recurrence. So I think you need to be very experienced in doing those, and usually they are not small. So I don't see. I'm sure some people can do an endoscopic resection of them, but I don't think it's extremely feasible. Yes, endoscopic resection in T1 adenocarcinoma of the stomach in the experienced hands are feasible. Management of carcinoid syndrome, you can take the tumor, the primary, and do debulking, and also give octreotide analogs. All right. I think we are done with the questions.